think we should start. Okay, can anyone tell me that can you hear me loud and clear? Please, anyone can confirm me that my voice is loud and clear. Okay, now I think we should start. In coagulation disorder, anti-clotting drugs, in which anticoagulants, thrombolytics, antiplatelet drugs. So these are the three major groups, right? And as the name indicate, the drugs which are responsible to prevent the process of clotting. As you know, if clot is formed, it's a disease phenomena. It can obstruct the vessel lumen, right? And drugs that facilitate clotting, like vitamin K, replacement factor, antiplasmin drug. So these are the main group and main classification: anti-clotting drugs as well as drugs that facilitate clotting. Okay, first of all, we discuss the blood clotting phenomena. You know, if there is any puncture, any damage, initially vessels, they try to constrict. They try to constrict to prevent the oozing of blood. But if that is not controlled by the vascular spasm, vascular constriction, so the next phase start. That is the platelet phase, in which platelet aggregation is start to prevent that puncture, that one. Then coagulation phase start, and finally when the bleeding is stopped, and then now this clot should be removed, because otherwise it would be harmful. So that is why endogenously fibrinolytic phase is also there. Now this slide is very important, right? So on the basis of this slide, we will be able to identify the group of drug that can be used. You know, there are two pathways: intrinsic pathway, extrinsic pathway. One thing is very important. One thing is very important, whether intrinsic pathway or extrinsic pathway. As you know, intrinsic pathway is activated when there is injury in the blood vessel, and intrinsic pathway is activated when there is a injury in tissue. But what is important, whether the activation of extrinsic pathway or intrinsic pathway. You can see ultimately, if first we say extrinsic pathway, okay, the purpose of extrinsic pathway ultimately is to activate factor 10. And if we see intrinsic pathway, here you can see the activation of again factor 10, right? So whether the intrinsic pathway or extrinsic pathway, so this is that is why this is called common pathway. So both are responsible to activate factor 10. The next question is, why activation of factor 10? Because this is the activated factor 10 which is responsible to convert factor 2 inactive form into active form, which is prothrombin. So activated factor 10 activate prothrombin into thrombin, and this thrombin is responsible to activate fibrinogen, and this fibrinogen activation is ultimately responsible to form the fibrin threads, right, and fibrin polymer, and they try to stop the bleeding. So again, I am quickly repeating, whether the intrinsic pathway or extrinsic pathway, the purpose of both pathway to activate factor 10, right? So if we are interested now here, if we are going to discuss at this level, now you know this factor 10 activation of thrombin, activation of fibrin, that is responsible to form fibrin clot, right? So if we are interested to prevent the formation of clot, what we can do? Either one of the mechanism to stop the activation of factor 10 or inactivate factor 10. When there is no activity or activated factor 10, there is no activation of prothrombin into thrombin. And when there is no activation of thrombin, so there is no formation of fibrin clot, right? So one of the group is there that we will discuss that will inactivate factor 10. And the drug can also inactivate thrombin, right? So this is important. Now, anticoagulants, one by one. Anticoagulants, we have heparins, we have direct thrombin inhibitors. Now you can recall, now you can understand, because we have focused on two important steps. One is the activation of factor 10, which is responsible to activate prothrombin into thrombin. So there are some drugs that can inactivate both factor 10 and factor 2, which is thrombin. But there are some drugs that can directly inhibit activity of thrombin, right? So these are three major groups: heparin, direct thrombin inhibitors, and warfarin. Now, one by one, this is very important topic. Heparin is a large sulfated polysaccharide polymer obtained from animal source. You know, anything which is derived, this is the basic concept, which is derived from the animal source, there is a chance of hypersensitivity reaction, there is a chance of formation of antibodies. Average molecular weight of heparin is 15,000 to 20,000. That means it's a large molecule. Heparin is highly acidic and can be neutralized by a basic molecule, that is the protamine. So this is very important point from the BCQ point of view, from the Viva point of view. That means because heparin is anticoagulant, that means it prevents the process of clotting. So if there is increased dose of heparin, there is a chance of bleeding. There is a chance of bleeding. This is one of the major concern. So we'll have to be very calculated if we are going to start the therapy with heparin. So accidentally or due to overdose, right? So how we can reverse this bleeding? There is an antidote, and which is protamine. And this is one of the commonly asked question in case of overdose of heparin or toxicity. Which antidote you will recommend? That is the protamine sulfate, because heparin is highly acidic and this protamine sulfate can basic molecule and it will neutralize the activity of heparin. Clear? This is very important point that you must remember. And there is another importance of knowing the high molecular weight, right? High molecular weight. So one of the important point is, because of its high molecular weight or polysaccharide structure, it cannot crosses the placental barrier. So is there any importance to know this point? Yes, because if there is a need to give the anticoagulant during pregnancy, so this is one of the ideal group that can be given during pregnancy because it cannot crosses the placental barrier. Okay, heparin is given intravenously or subcutaneously, right? This is one of the route of administration, and this point is important. Intramuscular or IM injection should be avoided because there is a chance, there is a risk of the hematoma. Now, heparin is a large molecule, right? We can say unfractionated form. But if we make the fractions of unfractionated heparin, we can get the low molecular weight or fractionated form of heparin. And one of the key drug, prototype drug of this group is the enoxaparin, and its molecular weight around 2,000 to 6,000. As we have seen that in case of heparin, 15,000 to 20,000. So it's a low molecular weight. So why it is important to know this? Clinically, you know, commonly we are preferring low molecular weight heparin. Like the key example is enoxaparin. There is another example, dalteparin, right? So why we are preferring this? Because this low molecular weight heparin having greater bioavailability, maximum concentration of drug available in the bloodstream without any changing, longer duration of action. So again, this is one of the important conceptual point that any drug, if having longer half-life, so least frequency is required. That means once or twice a day dosing would be sufficient. So doses can be given less frequently, once or twice a day. They are given subcutaneously. This is a molecule. Fondaparinux is a small synthetic drug and that is administered subcutaneously once daily. Because nowadays in current clinical practice, patient compliance is very important, and patient, they ask that, "Oh, okay, doctor, please give me the drug that least I should take," right? Least I should take. So if we are giving Fondaparinux, so once daily dose would be sufficient, right? Now, how it's going to produce its anticoagulant effect, this heparin? So, unfractionated heparin binds to endogenous antithrombin 3. So, this is the antithrombin 3, which is endogenous, right? Present in the body. So, what this heparin will do? This heparin or antithrombin 3 complex combines with an irreversibly inactivates thrombin and factor 10. So initially that's why we were focusing on these two steps, right? So this heparin can inhibit the activity of thrombin and factor 10 when it will combine with endogenous antithrombin 3. So in the presence of heparin, antithrombin 3 proteolyzes thrombin and factor 10 approximately 1,000 times faster than in its absence. So basically we can say that this heparin basically enhances the activity of endogenous antithrombin 3. Okay, this is another very important point, right? Suppose we have started the therapy like anticoagulant therapy. So how we can monitor the blood concentration? Because already we have discussed, if the drug concentration raises or increases, what it will do, it will cause bleeding. So continuously we'll have to monitor. When we have started the therapy, we must monitor the blood concentration. And if a patient is on heparin, the laboratory test that we recommend, that is the APTT, activated partial thromboplastin time. This is important. And another important I want to clear at this level, any drug, when APTT monitoring is effective and is necessary, if the drug is going to inhibit the activity of thrombin, if a drug is not going to inhibit the activity of thrombin, that APTT test wouldn't be reliable, because heparin can inhibit the activity of thrombin as well as factor 10. So we can check the level of drug by monitoring APTT test. Okay, now this is important. Low molecular weight heparin like deltaparin, enoxaparin, right, and fondaparinux, which is a small molecule, like unfractionated heparin, bind with antithrombin 3. This is the same. But what is the difference that we will see in the subsequent lines? These complexes have the same inhibitory effect on factor 10 as the unfractionated heparin 83 complex. However, the short chain heparin 83 and fondaparinux 83 complexes provide a more selective action because they fail to affect thrombin. And this is the point that you must remember, right? Because it's not going to inhibit the activity of thrombin, so APTT wouldn't be reliable, right? So the APTT test does not reliably measure the anticoagulant effect of the low molecular weight heparin and fondaparinux. This is a potential problem, especially in renal failure, in which their clearance may be decreased. So what is the point that you must remember? That any anti-clotting drug, if it's going to inhibit the activity of, we can monitor the drug activity of that drug that inhibit the activity of thrombin by which laboratory test? APTT, right? But if a drug is not going to affect the thrombin, the use of APTT wouldn't be reliable. Clinical uses, common uses include treatment of pulmonary embolism, acute myocardial infarction, and used in combination with thrombolytics for revascularization, right? used in combination with glycoprotein 2b3a inhibitor. This is a receptor, glycoprotein 2b3a, that we will discuss in the subsequent slide, right? So, and this is one of the important receptors that promote platelet aggregation, right? And you know, and you must know, platelet aggregation is a first step towards the formation of clot, right? So one of the use of this heparin or low molecular weight heparin is in combination with glycoprotein 2b3a inhibitors during angioplasty and placement of coronary stents. Because it doesn't cross the placental barrier, this point already we have discussed. Heparin is the drug of choice when an anticoagulant must be used in pregnancy. So this is one of the questions that is asked, okay, during pregnancy, which anticoagulant you can use? Can you use heparin? Yes, because it cannot crosses the placental barrier. Can we use warfarin? No, because it crosses the placental barrier because of low molecular weight, highly lipid soluble, and can causes the birth defects. Toxicity. And if we say there is a general concept, anything which is going to inhibit the clotting mechanism, there is a chance of bleeding. So increased bleeding is the most common adverse effect of heparin. The bleeding may result in hemorrhagic stroke. Unfractionated heparin causes moderate, this is important point, and this is the point that usually asked in the USMLE exam. Definitely there are some students who are interested to appear in USMLE exam in the future, so they must focus on this point. So unfractionated heparin, that is the high molecular weight heparin, causes moderate transient thrombocytopenia in many patients. So chances of thrombocytopenia, but fortunately that is the transient. But in and severe thrombocytopenia and thrombosis, that is called heparin induced thrombocytopenia or HIT, in a small percentage of patients, right? So this point is important. And sometimes the question which is asked, okay, there is a patient and having a history of thrombocytopenia, so which alternative drug you can use? And this is one of the commonly asked questions, especially in USMLE exam. So that we will see in the subsequent slide. But this important side effects you must try to remember. Chances of transient thrombocytopenia, fortunately, that is the in moderate cases, but in some cases there is a chance of severe thrombocytopenia. Low molecular weight heparin and fondaparinux are less likely to cause this immune mediated thrombocytopenia, right? And this point already we have discussed, because the heparin that is derived from the animal source, and in the beginning we have discussed that there is a chance of reaction. But low molecular weight heparin and fondaparinux are less likely to cause this immune mediated thrombocytopenia. Okay, this is another very important point. Prolonged use of unfractionated heparin is associated with osteoporosis, right? So now this is the second group, because in the beginning we show you anticoagulants, heparin we have done. Now we are discussing direct thrombin inhibitor, and which is factor 2. And in the initial slide we discussed that activation of thrombin basically is responsible to activate fibrinogen into fibrin, and then fibrin is responsible to form the fibrin clots. So there are drugs like direct thrombin inhibitors are based on proteins made by Heredo medicinalis, the medicinal leech. Lapiridine is the recombinant form of the leech protein heredin. But clinically, this drug is not being used. But we come to know because of this lapiridine, and we have derived another drug that we are using, while daceridine and bivaleuridine are modified forms of heredin. And this bivaleuridine, very important drug from the exam point of view. Again, I'm telling you, if you will check the pool of USMLE exam, one of the questions you will find related to this bivaleuridine. Okay, if a patient having a history of thrombocytopenia with heparin, so which is the alternative drug we can use? So you will have to select this bivaleuridine, right? And there is another drug that can also be used, in a patient having a history of thrombocytopenia, heparin-induced thrombocytopenia, or gatroban, which is a small molecule with a short half-life. All four drugs are administered parenterally. And this is there is another important point of this bivalirudin. Bivalirudin, what you must identify is direct thrombin inhibitor, right? Can be used as alternative if patient having a history of heparin-induced thrombocytopenia. And there is another important point related to this bivalirudin. This is the additional activity of this bivalirudin is it inhibits platelet aggregation, right? So mechanism and effects: the protein analog of lapiridine binds simultaneously to the active site of thrombin and thrombin substrates. Bivalirudin also inhibit platelet activation. This is important point you must remember. Clinical uses: direct thrombin inhibitors are used as alternative this to heparin, primarily in patient with heparin-induced thrombocytopenia. So this point already we have discussed, and this is the point that is important from the BCQ point of view. Bivalirudin also is used in combination with aspirin during percutaneous coronary angioplasty. Like unfractionated heparin, the action of these drugs is monitored with the APTT laboratory test. Now you will realize that the key point already I have told you. Any drug, if it's going to inhibit the activity of thrombin, we can check the activity of that drug by performing which laboratory test? APTT. Toxicity: like other anticoagulants, the direct thrombin inhibitors can cause bleeding, and no reversal agents exist. So this is one of the drawback. There are many advantages, but this is one of the drawback, because in case of heparin, we have an antidote which is available. And what is the name of that antidote? Protamine sulfate. So prolonged infusion of lapiridine can induce antibodies that form a complex with lapiridine and prolong its action, and it can induce anaphylactic reactions. Now, direct factor 10 inhibitor, activated factor 10 inhibitor. Now I think you are realizing the importance of that first slide, in which we were discussing that whether intrinsic pathway or extrinsic pathway, ultimately both pathway has to activate factor 10. And this activated factor 10 is responsible to activate prothrombin into thrombin. Then thrombin is going to activate fibrinogen into fibrin. Then fibrin clot is formed. So we have direct thrombin inhibitor, we have thrombin as well as factor 10 inhibitor, which is heparin, and we have direct thrombin inhibitor, in which we have discussed the lapiridine derivative like bivalirudin, ergotroban. Now we have direct factor 10 inhibitor. So rivaroxaban. And clinically, what is the important point that I want to share with you nowadays? Rivaroxaban, this direct factor 10 inhibitor, we are using commonly. We are using this group and replacing warfarin, right? Rivaroxaban is still warfarin is being used, but rivaroxaban having less side effects if we compare with warfarin. There is no drug-drug interaction that we find in case of warfarin. Okay, that we will discuss in the subsequent slide. But what you must know, direct factor 10 inhibitor, rivaroxaban, very important drug, and other dravans used to prevent deep venous thrombosis, especially after knee or hip surgery, in which patient is bedridden, so increased chances of deep vein thrombosis. Prevention of stroke and systemic embolism in non-valvular atrial fibrillation. Now this important point, right? Now this is very important group, right? Warfarin and other coumarin anticoagulants, and this is one of the drug that is asked commonly. So basically warfarin is a coumarin derivative. So sometimes in the exam, in the BCQ, the examiner just mentioned the coumarin word. So if there is a coumarin word, definitely what they are going to ask regarding warfarin. This is important point that you must remember. Warfarin and other coumarin anticoagulants are small lipid soluble molecule, and these are the two reasons: a small structure and highly lipid soluble, so it can crosses the placental barrier, right? So that is why during pregnancy warfarin is contraindicated. Readily absorb after oral administration, that means rapidly absorb after oral administration. Oral administration, when we give it orally, its absorption is good, excellent. Warfarin is highly bound to plasma protein. Is there any clinical importance of knowing this? This is the general concept. Any drug having the ability to bind with plasma protein. So what is the clinical point? What is the clinical importance? Any drug having high protein binding ability increase chances of drug-drug interaction. What does it mean, drug-drug interaction? You know, because any other drug that can replaces the already bound drug. So when the drug is in free form, basically that is in active form. Till drug is bound with the plasma protein, the binding form is the inactive form. For the activity, it must be free from its binding site. So any other drug, if it displaces the bound drug from its binding site, so the level of that drug will raise. So increased chances of toxic effect, right? So warfarin is highly bound to plasma protein. So warfarin is one of the example having strong protein binding ability, and its elimination depends on metabolism by cytochrome P450 enzymes. And you will find a lot of BCQs related to this concept. And again, this is one of the general concept. Any drug which is metabolized by the cytochrome P450 enzyme, again, there is a chance of drug-drug interaction, because if a patient is taking multiple drugs and one of the drug is going to inhibit cytochrome P450 enzyme activity, so what will happen? The metabolism of warfarin will not occur. When there is no metabolism, there is no elimination. So what will happen? When there is no elimination, increased level of warfarin in the blood. So what will happen? Is there any problem? Yes. Bleeding will start from all the orifices of the body. And similarly, if a patient is taking multiple drug, right, for comorbidities, and one of the drug enhancing or inducing the cytochrome P450 enzyme, what will happen? The early metabolism, quick metabolism, and drug is going to be eliminated. So is there any problem? Yes, because the drug, when drug is not present in the blood, how it's going to maintain the therapeutic activity? Clear? So this is how this drug-drug interaction can take place. So this is one of the diagram. This is one of the slide in which we can express or explain the mechanism of action of warfarin. This is important. How it's going to produce anti-clotting activity. Vitamin K dependent clotting factors which are synthesized in the liver. And what are those clotting factors? Factor 2, 7, 9, 10. 2, 7, 9, 10. These are the clotting factors which are synthesized in the liver, and their synthesis dependent on vitamin K. And which form of vitamin K? Reduced form or oxidized form? Reduced form of vitamin K is required, right, for the synthesis of these clotting factor. And this conversion of vitamin K from epoxide to reduced form of vitamin K is required the vitamin K epoxide reductase enzyme, right? So if we give warfarin, it will inhibit the activity of vitamin K epoxide reductase enzyme. So reduced form of it available, which is necessary for these clotting factors, factor 2, 7, 9, 10, right? So warfarin blocks the vitamin K dependent glutamate carboxylation of precursors clotting factors. Now, this is the explanation. Warfarin and other coumarin interfere with the normal post-translational modification of clotting factors in the liver, a process that depends on an adequate supply of reduced vitamin K. The drug inhibits vitamin K epoxide reductase, which normally converts vitamin K epoxide to reduced vitamin K. This already we have discussed. The vitamin K dependent factors include thrombin, which is factor 2, and factor 7, 9, and 10. Because the clotting factors have half-lives of 8 to 60 hours, right? So different clotting factors having different half-life in the plasma. An anticoagulant effect is observed only after sufficient time has passed for elimination of the normal preform factors. Here I want to share or want to discuss very important point. What is that? In emergency, if we are required the anti-clotting activity, we cannot give warfarin. Okay, why? Because warfarin will take time. Whereas in emergency, we can give heparin. So what is the difference? This is one of the questions commonly asked, why the onset of action of warfarin is slower. Now I am explaining it. You know, heparin, why its activity is rapid? Because it's inhibit the activity of preform clotting factors. But warfarin basically inhibit the synthesis of clotting factors. Okay, when you have started the therapy with warfarin, okay, it will inhibit the further synthesis of clotting factors. But the clotting factors which are already synthesized, it will produce its activity until they are going to be eliminated, they are going to be excreted out from the body. So that is why it takes time to produce its activity. The action of warfarin can be reversed with vitamin K. This is one of the antidote. But recovery requires, again, the recovery requires the synthesis of new normal clotting factors and therefore slow. So if you are required the quick effect, what we can do? We can give we can transfuse the fresh or frozen plasma, because in plasma, you know, we have preformed clotting factors, right? So in emergency situation, in case of warfarin toxicity, how we can reverse? We can reverse the bleeding by giving fresh or frozen plasma, right? The effect of warfarin, this is important point. The effect of heparin can be monitored with which laboratory test? APTT, but the effect of warfarin is monitored by the laboratory test, which is prothrombin time PT test. Clinical uses, warfarin is used for chronic anticoagulation in all of the clinical situation what we have discussed in case of heparin, except in pregnant women, right? The reason already we have discussed. Toxicity, bleeding, again, is the most important adverse effects of warfarin. Early in therapy, a period of hypercoagulability with subsequent dermal vascular necrosis can occur. And this is due to deficiency of protein C, an endogenous vitamin K dependent anticoagulant with a short half-life. Warfarin is contraindicated in pregnancy because it can cause bone defects and hemorrhage in the developing fetus. Okay, this also we have discussed the drug-drug interaction. Warfarin has a narrow therapeutic window. What does it mean? The difference between the therapeutic dose and lethal dose is shorter. So if we prescribe the warfarin or accidentally if we double the dose, so what will happen with that patient? You can imagine the bleeding from all the orifices of the body, right? So always, this is again the general concept, any drug having low therapeutic index, narrow therapeutic window, will have to be very, very careful when we are going to calculate the dose, right? Now, one of the point already we have discussed, warfarin having drug-drug interaction, because warfarin is metabolized by the cytochrome P450 enzyme family. So if any other drug that can inhibit the metabolism of warfarin, ultimately the level of warfarin will raise and it will produce the toxicity. Similarly, if a drug like carbamazepine, phenytoin, rifampin, barbiturates, they are going to stimulate or induce P450 enzyme. So early metabolism, quick metabolism, so increase warfarin's clearance and reduce the anticoagulant effect of a given dose. Cytochrome P450 enzyme inhibitors like amiodarone, selective serotonin reuptake inhibitors, cimetidine use warfarin clearance because the metabolism of warfarin is necessary for its elimination. So any drug, if it will inhibit P450 enzyme, so slow metabolism, right, reduce metabolism, so ultimately the level of warfarin will raise and increase the anticoagulant effect of given dose. So this is the difference between heparin and warfarin, right? Because we have discussed in very much detail. So I'm skipping the slide because we'll have to finish this lecture. It's a very extensive lecture, right? Now, thrombolytic agents. Okay, the clot has been formed, right? Clot, one of the process to prevent the formation of clot that we can achieve by giving anticoagulants or antiplatelet drugs. But if the clot has been formed, now it will disturb the normal blood flow, right? Because in brain it will cause ischemia, in heart it will cause angina, in chances of myocardial infarction, right? So the thrombolytic drugs used most commonly are endogenous tissue plasminogen activator, for example alteplase, tenecteplase and retiplase. Very effective drug, right? But very much expensive, right? A protein synthesized by streptokinase, right? So streptokinase, this is one of the drugs that is being used commonly in our ward, right? But this drug streptokinase is synthesized derived from the protein of streptococci. So already we have discussed. So increased chances of formation of antibodies, right? So all the drugs are given intravenously. Another very important point that we will discuss in the subsequent slide related to this point, that this streptokinase, or in short form, you will see in the words the word SK. SK means streptokinase, right? And the protein synthesized by streptococci. There is a very important point related to this point that we will discuss in the subsequent slide. But mechanism of action, how it's going to dissolve the clot, plasmin, which is an endogenous fibrinolytic enzyme that degrades clot by splitting fibrin into fragments, right? Because already we have discussed fibrin fragment or thread that is responsible to form a clot. Now this plasmin, which is endogenous fibrinolytic enzyme that degrades clot by splitting fibrin threads into fragments, and the thrombolytic enzymes catalyze the conversion of the inactive precursor plasminogen to plasmin. So plasmin is responsible to dissolve the clot, to break down the fibrin clot. If we just recall, okay, thrombin is derived from the prothrombin, and thrombin is responsible to promote fibrinogen into fibrin. But plasmin, that is responsible to dissolve the fibrin clot by breaking down the fibrin, right? Now this is the diagram. You can see the plasmin, and plasmin is responsible to split the fibrin products, right? And fibrinogen converted into fibrin and ultimate, right? Tissue plasminogen activator is an enzyme that directly converts plasminogen to plasmin. Examples are alteplase is normal human plasminogen activator. Retiplase is a mutated form of human tissue plasminogen activator with similar effect but a slightly faster onset of action and longer duration of action. Tenecteplase is another mutated form of tissue plasminogen activator with a longer half-life. Now, this is very important from the exam point of view, is streptokinase, and this streptokinase is obtained from bacterial cultures. Streptokinase form a complex with endogenous plasminogen, and this complex rapidly convert free plasminogen into plasmin. Streptokinase doesn't show selectivity for fibrin-bound plasminogen. Clinical uses of streptokinase as an alternative to percutaneous coronary angioplasty in the emergency treatment of coronary artery thrombosis can promote, this is important point, can promptly recanalize the occluded coronary vessel if treatment is started within 6 hours. In patient with ischemic stroke, if tissue plasminogen activator is used within 3 hours of the first symptom, will show significant better clinical outcome. But one important point, before starting the drug, you must rule out the cerebral hemorrhage. Cerebral hemorrhage must be positively ruled out before such use, right? This is important point, right? All use in cases of severe pulmonary embolism. Toxicity, again, bleeding is the most important hazard. Cerebral hemorrhage is the most serious manifestation. So we'll have to be very, very careful if we are suspect that this patient having TIA, transient ischemic attack. So before starting therapy, we must rule out whether this stroke is the ischemic stroke or hemorrhagic stroke. Clear? Now, this point that I was telling you, that streptokinase, a bacterial protein, can evoke the production of antibodies that cause it to lose its effectiveness or induce severe allergic reactions on the subsequent therapy, right? This is important. Okay, first time injection will produce the maximum activity, but if the second time and at the same time after a short period of time, after a short gap, so most probably chances of losing its effectiveness or sometimes may produce allergic reaction due to the formation of antibodies which were formed on the first exposure, right? So patients who have had a streptococcal infection may have preformed antibodies to the drug, right? So the recombinant form of tissue plasminogen activator are not subject to this problem because they are human proteins. Now the antiplatelet drugs. Platelet aggregation. This point already we have discussed. Platelet aggregation is the first step towards the formation of clot. So platelet aggregation contributes to the clotting process and is especially important in clots that form in the arterial circulation. And antiplatelet drugs, they are highly effective against arteries rather than veins, right? So platelet aggregation, now this is important point. Platelet aggregation is triggered or stimulated by prostaglandin thromboxane, adenosine diphosphate, thrombin, and fibrin. So these are the factors which are responsible to promote platelet aggregation. But platelet aggregation is inhibited by cyclic AMP, prostaglandin, prostacyclin, right, and adenosine. So these are the factors which are responsible to prevent platelet aggregation. Classification of antiplatelet drugs. Antiplatelet drugs, like NSAID, include aspirin, and this is one of the commonly used drug, right, in our clinical setup. But nowadays, you know, the coated form of aspirin is being used. There are multiple reasons why aspirin is being used, because it's a cheaper drug. But if we just use aspirin, increase chances of ulcer. So that is why the coated form of aspirin is available to prevent or to reduce the ulcer, because even coated form of aspirin, there is formation of ulcer, there is acidity. This is one of the major concern, major problem when we use aspirin. Otherwise very much effective, and we take it prophylactically to prevent the future attack. And the coated form of aspirin is called Ascard, right? Ascard. Okay, the second group, glycoprotein 2b3a receptor, because this is one of the protein complex that promote platelet aggregation. Abciximab, terifibran, and eptifibatide. So these are the examples of drugs that inhibit the glycoprotein 2b3 receptors, which are located on platelets. Antagonist of ADP receptor, because already we have discussed in the previous slide that this ADP is responsible to promote platelet aggregation, one of the mechanisms. So clopidogrel and ticlopidine, they are going to inhibit the ADP receptor activity, so prevent the platelet aggregation. Now, another group, inhibitor of phosphodiesterase enzyme type 3. And examples are diaperitamol and clostazole. You know, phospho, what we have discussed, cyclic AMP, that is responsible to prevent platelet aggregation. And you know, phosphodiesterase enzyme is responsible to break down the cyclic AMP. So, but to prevent the platelet aggregation, we are interested to raise the level of cyclic AMP. So this is one of the mechanisms. If we inhibit the activity of phosphodiesterase enzyme, there is no breakdown, no degradation of cyclic AMP. So the level of cyclic AMP will increase and it will prevent the platelet aggregation. So inhibitor of phosphodiesterase enzyme examples are diaperitamol and clostazole. Mechanism of action, like aspirin and other NSAID inhibit thromboxane synthesis by blocking the enzyme cyclooxygenase enzyme. You know, aspirin inhibit the cyclooxygenase enzyme non-selectively. That means it will inhibit COX-1 as well as COX-2. And this inhibition is irreversible. This is one of the exceptional point if we compare with NSAID with other NSAID, right? Aspirin is the only drug that inhibit the cyclooxygenase enzyme irreversibly, because thromboxane A2 is a potent stimulator of platelet aggregation. So that is why we want to inhibit the formation of thromboxane synthesis, which is formed through cyclooxygenase pathway. Aspirin, an irreversible COX inhibitor, is particularly effective. This glycoprotein 2b3 receptor antagonist, at least if you just remember the name, abciximab, eptifibatide, terifibran, that would be enough. Is a monoclonal antibody that reversibly inhibits the binding of fibrin and other ligands to platelet glycoprotein 2b3 receptor, which is a cell surface protein involved in platelet cross-linking. Eptifibatide and terifibran also reversibly block the glycoprotein 2b3A receptor. Now, this ADP receptor antagonist, examples are clopidogrel and other older drugs, ticlopidine, are converted in the liver to active metabolites that irreversibly inhibit the platelet ADP receptor and thereby prevent ADP-mediated platelet aggregation. Now, this phosphodiesterase enzyme inhibitor, already we have discussed why we are interested to inhibit this enzyme, because this enzyme is responsible for the breakdown of cyclic AMP, and cyclic AMP reverses the platelet aggregation, right? Prevent the platelet aggregation. So if we inhibit this enzyme, we can avoid the breakdown of cyclic AMP, so we can raise the level of cyclic AMP. So examples are diaperitamol and the newer clostazole appear to have a dual mechanism of action. They prolong the platelet inhibiting action by inhibiting phosphodiesterase enzyme that degrade cyclic nucleotides. They also inhibit the uptake of adenosine by endothelial cells and erythrocyte, and thereby increase the plasma concentration of adenosine. And this is adenosine, this is another compound which is responsible to prevent platelet aggregation. Adenosine acts through platelet adenosine 2 receptors to increase platelet cyclic AMP and inhibit aggregation. Clinical uses of antiplatelet drugs. Aspirin is used to prevent further infarcts in persons who have had one or more myocardial infarcts and may also reduce the incidence of first infarct. The drug is used extensively to prevent transient ischemic attack, ischemic stroke, and other thrombotic events. The glycoprotein 2b3 inhibitors prevent, this is important use of this glycoprotein 2b3 inhibitors, prevent restenosis after coronary angioplasty and are used in acute coronary syndrome like unstable angina and non-Q wave acute myocardial infarction. Clopidogrel and ticlopidine are effective in preventing transient ischemic attack and ischemic stroke, especially in patients who cannot tolerate aspirin. So sometimes patients show the hypersensitivity reaction against the aspirin. So in that patient, clopidogrel is the best alternative. Clopidogrel is routinely used to prevent thrombosis in patients who have received a coronary artery stent. Diparacetamol is approved as an adjunct to warfarin in the prevention of thrombosis in those with cardiac valve replacement and has been used in combination with aspirin for secondary prevention of ischemic stroke. Clystazole is used to treat intermittent claudication, a manifestation of peripheral arterial disease. Toxicity, aspirin and other NSAID causes gastrointestinal and CNS effect. Main problem is related to ulcer. All antiplatelet drugs significantly enhance the effect of other anti-clotting agents. The major toxicities of glycoprotein 2b3 receptor blocking drugs are bleeding and with chronic use, thrombocytopenia. Ticlopidine is used rarely. Why? We are using clopidogrel if there is a need, right? Ticlopidine is used rarely, almost obsolete. Its use is obsolete. Why? Because it causes bleeding in up to 5% of patients, severe neutropenia in about 1%, and very rarely thrombotic thrombocytopenic purpura, a syndrome characterized by disseminated formation of small thrombi, platelet consumption, and thrombocytopenia. But clopidogrel is less hematotoxic. That's why it's being used. The most common adverse effect of diparacetamol and clystazole are headache and palpitations. Clystazole is contraindicated in patients with congestive heart failure because of evidence of reduced survival. So this is all about the anticoagulation, and thank you so much for being with me.